Hi, Mike Gibson, Carolyn Lam coming to you live from ESC 2021, and we are talking about Emperor Preserved, I think the talk of the town in Amsterdam. Carolyn, you were one of the co-authors on this landmark study. Congratulations. I think it really does change practice. It's a landmark study. Do a bit of a deep dive for us and talk to us about why you guys did it and what you found and how it changes practice.
Wow. Okay. So first, let me tell you about the trial. So Emperor Preserved was a trial of almost 6,000 patients with heart failure and ejection fraction above 40%. They could be diabetic or non-diabetic. Their GFR could go down to as low as 20. And they were randomized to empagliflozin 10 milligrams a day versus placebo. And over a median follow-up of 26 months, it was the first robustly positive outcomes trial in HFpEF, meaning that empagliflozin significantly reduced the primary outcome of cardiovascular death or heart failure hospitalization by 21%. So
Wow.
that was super.
And when I looked at the absolute risk reduction, it was pretty sizable. And because that drives the NNT, I got an NNT of around 30. I mean, that's very good.
It is. We do have to recognize it was driven mainly by the heart failure hospitalization reduction, and there was no significant impact on cardiovascular death or all-cause mortality. Of course, that gets talked about a bit, but I again don't want to lose the story that hospitalization is a very important outcome to these patients.
Yeah. I mean, people at the
And
end of the day, they want to be alive and they want to be out of the hospital. So we're not only just trying to add years to people's lives, we're also trying to add life to people's years. And so I think people look at both those, in some of the studies I do, the endpoint we're starting to use is how many days are you alive and out of the hospital? So
That's a really good point. Oncology trials use that, and I'm beginning to think more and more that we need to learn a little bit more of those trial methodologies in conditions like HFpEF, honestly, that have a outcome as dismal as cancers, and affect very elderly patients who really, really just want days alive and well out of hospital. So
But I
that's
also
a
want
very
to
good
tell the
point.
audience that the EFs here were pretty good. I mean, two-thirds of people had an EF above 50%. The median EF was 54%. So talk about preserved. These were pretty preserved EFs.
Yeah, yeah. And taken as a complete trial, I mean, it was positive. The primary endpoint was the composite. It was positive. The two secondary endpoints were also positive. And the first secondary was total heart failure hospitalization that was reduced by 27%. And the second secondary endpoint was the GFR decline, and the slope was halved by empagliflozin, also a
Wow.
significant difference. So this was a successful trial. We should always consider the safety profile, and that's the beauty of the SGLT2 inhibitors. What we saw in Emperor Preserved was very consistent with what we've seen in the cardiovascular outcomes trials in Emperor Reduced, for example. So very safe and well tolerated, a little bit more hypotension, genital and urinary tract infections, but these were generally mild infections, and didn't cause excessive discontinuation of therapies. So I think a true example of heart success.
Absolutely. Big heart success, smashing success. There was also pooled analysis of some of the data. Talk to us about that.
Oh, the pooled analysis was very interesting because it was the primary endpoint there was a renal endpoint. And what it is a individual level meta-analysis of Emperor Reduced and Emperor Preserved, right? With that renal outcome as the primary endpoint. Interestingly, there was a interaction by trial such that the renal endpoint was robustly met in Emperor Reduced, but not quite in Emperor Preserved. And I think we're still trying to wrap our heads around that because we clearly saw a benefit in terms of the slope, the GFR slope, Although if you line up emperor reduce and emperor preserve, that slope benefit was less in emperor preserve. But there's a bit of a disconnect, and there was a lot of analyses, different analyses done by the team looking at the way you define renal endpoints. So I think we're going to learn a lot about the trial, because when we defined it differently, we did get a different answer. And that is when we use a more stringent GFR decline as part of the renal endpoint of 50% or more and included renal death, then you saw that there would start to have a benefit. So I think we're going to learn a lot from that, and much, much more to come. But it's very nice to see that if you line up emperor preserve and emperor reduce, those three hierarchical endpoints of the primary composite, total heart failure hospitalization, are very consistent between the two trials.
It's kind of interesting. We all make binary decisions. So we like binary divisions of people into preserved or reduced. But EF is a continuous variable. And a lot of times in regulatory analyses, we move away from binary kind of looks at the data to using it as a continuous variable to see how, for instance, EF as a continuous variable, how it's related to these kinds of outcomes. And I'm sure you guys will be looking at that as well. Does the benefit all hold up at the very, very high end of the scale? Say you have an EF of 60.
Yeah. Mike, you're hitting the nail on the head. So that is the outcome that I just want to emphasize wasn't the primary outcome of Emperor Pool, right, which was renal, and that is looking at the heart failure hospitalizations. And it's true that when splines were done across the entire EF spectrum and with smaller cuts of the ejection fraction, there seemed to be an attenuation of the benefit on heart failure hospitalization at the highest ejection fraction of above 65%.
Right.
We've seen that pattern before with the ARBs, with the MRAs, even with the beta blockers, with the ARNIs. We're looking into that, I think, in more detail here. It's a bit confusing, and I just want to state it just so that people don't get confused, so we can actually call it what it is, because in Emperor Preserve, there was a pre-specified look at interaction by pre-specified EF subgroups, and that was not significant. And yet when we do it across this using a different outcome of heart failure hospitalizations, we see that difference. So I think we're going to spend a lot of time trying to understand what these patients with the very high ejection fraction have. And the new guidelines actually emphasize that, and I'm talking about the ESC guidelines, that we should be excluding pathologies like amyloid, hypertrophic cardiomyopathy in these patients.
Well, that's what I was going to ask you. It strikes me that this is a heterogeneous group of people who have HFpEF. And I was wondering what all of you were going to do about that. How are you going to, with all these different etiologies, there may be different responses. So I look forward to seeing how you're going to handle that.
Yep. I look forward to seeing how we'll handle that in future trials too. It'll be very interesting. A lot that we've learned, and glad to be here to talk about it.
Well, thanks for joining us, Carolyn, and thanks to all of you for joining us here live from ESC 2021. Congratulations, Carolyn, and to all the investigators. Clearly a landmark study. Thanks for changing practice.